Thanks very much for staying the course. It's Friday afternoon, and we're 3/4 of the way through an excellent meeting. My name's Arjun Jayaraj. I'm a gynae oncologist, and I'm chairing this session, which is a panel discussion that is bringing together, and we're absolutely delighted, the BGCS is absolutely delighted that we are collaborating with the Association of Surgical Oncologists for the first time, I gather, to put on an event like this. And cross-fertilization is always a good thing, and we're grateful for the lineup we have today, representing all the relevant surgical specialties that we work with. We've heard over the last couple of days that the radicality of surgery involving multiple systems is progressing. And obviously, we live and we learn. And today, we are basically asking the question, who should be doing what, where? We've got a great lineup of experts in their fields to tell us their thoughts and to address this issue. And I'm very hopeful that at the end of all of this, we can have a nice discussion. And can I ask the speakers that after you give your talks, if you could take a seat up here, and then we'll sort of proceed with a conversation with the audience afterwards. So without too much ado, we'll kick off with Professor Anand Desai, who leads the Super-Regional Sarcoma Service in Birmingham. Welcome, Professor Desai.
Thank you very much, and thank you for the opportunity to speak today. We've only got 5 minutes each, so it's...
It is rather tight, and I must also add that my co-chair, Jayant Vaidya, is unwell.
Yes,
so, yeah.
But I can help with the co-chairing.
Absolutely.
But
do go ahead, yes.
So I'm going to get on with it. So my name is Anand Desai. I'm a sarcoma surgeon in Birmingham. I'm also secretary of the British Association of Surgical Oncology and president of the British Sarcoma Group. So I do have a view on multidisciplinary working in radical gynae onc. I do quite a lot of it with my colleagues in Birmingham, who I'm sure you all know. So this was the brief, really. What types of patients do you believe should be managed jointly? How can joint working be employed during the patient journey? Where should procedures be undertaken? What procedures, and I didn't add this, if any, should a gynecologist not be, as if there were any, and what opportunities do you see for joint research and academic work? I'm going to concentrate. I'm probably going to dodge that one about what procedures, because I'd like, because I just want to see what the panel say. But I'll touch on the others now. So I'm just going to tell you the boring bit, really. So our sarcoma service specification. So which patients should come to us as sarcomas? We are organised, just to give you a bit of background, into 15 specialist centres, 5 bone and 10 soft tissue. And bone. And so in each centre basically hosts the MDT, and then there are designated local units that deliver some of the care. So all people, that is everybody, with suspected or confirmed diagnosis of sarcoma must be referred to a specialist sarcoma centre for review in the MDT. That's everybody. Surgery for some forms of soft tissue cancer, for example gynae, that requires the surgical expertise of other MDTs may be performed outside. So they all have to be discussed in the centre, but not all surgery has to happen there, which kind of makes sense. But that needs to be done by agreement, and it needs to be done within the guidance of the sarcoma MDT. Similarly, chemoradiotherapy we accept can be delivered outside the specialist centres, again with guidance. And this has been a very big bone of contention in Birmingham. Pathology for all sarcomas must be reviewed by a sarcoma pathologist. As you know, and our service specification is pragmatic, if nothing else, 2/3 of gynecological sarcomas diagnosed are not diagnosed preoperatively. And it usually is a situation where hysterectomy is done for a funny fibroid, and then they should be referred to the sarcoma MDT. A big thing for me is this medical school take-home message. The only thing that people remember about sarcoma is not to biopsy it, and in fact that's not the case. Done in the right way, in the right circumstances, biopsies are crucial, and not all soft tissue lumps in women are gynecological, and again we see problems in this setting. So this is our noddy pathway that Janos Baliga and I put together a few years ago. I hope you can see it, but essentially what it does is it says that the gynecological sarcoma will go to one of those MDTs in our region. It's either post-op diagnosis, pre-op, or recurrence. And as we said, mostly post-op. Referral to the sarcoma MDT, and then a number of different outcomes. So THBSO in your local centre, a radical pelvic surgery in Birmingham, abdominal surgery in Birmingham, or chemoradiotherapy either in Birmingham or locally. So we give people the option. Pathology for all gynecological sarcomas must be reviewed by a pathologist with a gynae interest and a sarcoma pathologist, and they must attend the meeting. That's never happened in Birmingham. I don't think it ever will. All cases of, as we've said, must be discussed at the MDT, and this just sort of just goes over what I've just said, the flow sheet. Cases requiring radical resection should really be operated on in a sarcoma centre, although we completely accept there's expertise out there for other procedures to be done locally, but it needs to have been discussed at the MDT. So these are often tragic cases of young women. The median age of gynecological sarcomas is 48, and again, every week we see young women with young children who've had unplanned surgery. There's no standardisation of care across the country for these women, and the research is poorly funded. We don't have this pink ribbon brigade, which is not my saying, but my oncologists. There are no drugs. It's such a rare group of patients that no companies want to invest in a loss-making drug. The main subtype is leiomyosarcoma, and we have this. So we have LMSR UK, which is a new charity, Leiomyosarcoma Research UK, and they've come up with this sort of all-encompassing trial idea, which they have asked me to show to you. I'm not going to go into this in any detail because I've got 12 seconds left, but essentially we accept fully that we need your engagement. We need gynae oncology, and in our workshop we've recognised that a good relationship with you guys is crucial. We probably need a standardised pathway nationally and work with you guys. And we're worried about gynecologists being sceptical about preoperative diagnosis, and clearly any research project we're going to do mostly needs preoperative diagnosis. I put to you that we could work together and have a research fellow to collect data, numbers, and start to work on some of these research ideas that we have. And I'm sort of here really to put a plug to you to help us try and move some of this research forward. So that's it. That's my 5 minutes. I hope that's covered most things. As I said, I've avoided who should do what and, and who shouldn't do what. And there we are. So this is young women with advanced gynecological sarcomas that are not diagnosed preoperatively. Thanks very much.
Thanks very much indeed. Can I call upon Zaid Hamadi from Southampton to tell us about the right upper quadrant of the abdomen, which is always a challenge.
Thank you very much, and it's been a pleasure and honor to be here. I'll talk about the holy site, right upper quadrant pain, and right upper quadrant of the abdomen. So, when do we need to discuss surgery for ovarian cancer? And I'm talking about mainly ovarian cancer. This is where we get involved in liver and pancreatic surgery. Either we do it as part of cytoreductive surgery, when I get called by my colleagues and help them clear some of the disease around the liver and the hilum. Or we do it as part of curative, where we need a major liver resection to achieve R0 resection and curative, and that's only when the liver specific metastasis and there's no extrahepatic disease. So it needs to be approached with a multidisciplinary ideas, and what we guided by oncological outcome, which is coming from you. And we serve here as a technicians, really. So quite often when we get these cases, it's not me to decide whether these are suitable for surgery or not. I will just say my opinion that I can take it out or not, and I will need your opinion to say, is this oncologically sound decision to take it out or not? Quite often we get referrals as well from breast surgeons asking us, can you take this out? I say, yes, I can take it out, but is it sound? And as you may know, breast cancer is quite different from ovarian cancer. And when they have got synchronous breast liver metastasis, this is almost always the oncologist will tell us off, and we don't touch them. So, and then we need to think about what anatomically resectable and what's anatomically not resectable, or near the hilum. as you may all know, liver is coming from live. If you don't have a liver, you don't live. It's more important than the heart. And if you kill the liver, you kill the patient. And that's quite really real. Patients die when they lose their liver, but they don't die when the heart stops, because you can still operate them on a machine, give them heart transplant. The liver is not like this. They kill them straight away. So we need to think about what magical structures that can keep your liver alive, which is the hepatic artery and the hilum and the portal vein. So this is just to show you some of the indication or risk prediction for liver metastasis. It's taken from just recent publication about prediction of liver metastasis in ovarian cancer. So we need to think about what are the resections that we can offer these patients. So we either do complete segment resection, for example, segment 2, 3, and you can think about the liver, they've got stations. And these segmentations are mainly dependent on the portal vein distributions. Or we do a formal, what we call it a right, in the old school days we used to call them right and left hepatectomies, or we do a wedge resection. Most likely that what you will see the liver surgeon, when they come and help you, they will do with the ovarian liver metastasis, they will do wedge resection. And quite often, more than often actually, they are just scrapping off the metastasis from the liver surface, because quite often the ovarian metastasis is superficial and peritoneal rather than true liver parenchymal metastasis. And what's important here, you can see that the hilum, this is what I talked about, the holy area. If you touch this area and you don't really careful to what you're dissecting around this area, the patient is gone, unfortunately. And we are quite careful about when we dissect in this area in the hilum. The pancreatic resection for ovarian metastasis, it can be quite straightforward, and I can imagine everybody who can do distal pancreatectomy. You may need us if you want to do Whipples, but we don't quite often do Whipples for patients with ovarian metastasis. However, what you need to think about it is the pancreatic juice is the most comorbid juice in the body. And if you've got a pancreatic leak, then the chance of mortality in that patient is going to be about 8%. It's quite significant. It doesn't mean that our hands is better than suturing it, but we may be able to deal with the complications because we see them every day. I'm not going to talk about what procedure you don't do. I'm sure you can do it all. But we will talk about that these procedures are proved to be safe, whether they are done by yourself or by ourselves, but it must be done safely and safer with a better outcome when they are done in a multidisciplinary team and a team working, because there's always a sequence, and then I'll come in the next couple of slides of what sequence we need to arrange and organize for these patients. So this is just a slide to show you that there is a good outcome actually from ovarian metastasis. However, when I reviewed the literature, there isn't much published about the long-term survival from ovarian metastasis to the liver. And I think it's an opportunity now in a time that we need a national registry. And you can drive this registry to help us understand what is the long-term outcome of resecting these patients with ovarian metastasis. I'll just pass this one now. I'll talk about anesthetist here is quite important, integral part of our surgery. The mortality since the liver anesthesia or low CVP anesthesia has been introduced in practice, the mortality in liver surgery has significantly reduced. And we are, as a group, we don't allow any anesthetist really to operate on our patients because they have got really different approach for liver patients than general anesthetic, and therefore involving them at an early stage with when we are undertaking liver resection particularly is quite important. And then we need to talk about the sequence. We usually go first. Whenever we do, that's not only with a gynecologist, with a colorectal surgeon, usually we need to go first because the anesthetist want to keep them very dry with a low CVP, and the patient gets sick and they will need inotropic support, and that's why we should do it first, quickly, get out, and then we leave all the field for you to do the rest of the resection. In addition, handling the liver, and obviously we spoke about the hilar handling. but we have got equipments to deal with the deeper liver resections, and particularly with open. We do it with using the ultrasonic dissector to try identify structures, clip them, and reduce the risk of not only bleeding, but mainly bile leak. And it's quite important how we deal with these complications. People, they die from complications most likely that they die from the surgery itself. Nobody will die on table because you've resected the liver or taken half the pancreas out, but quite often they will die 8 days later when they've got an infected pancreatic necrosis and infected pseudocyst that's not been managed. And I think there's really good time, as well as I concur what Anand just mentioned, that there is a time for a research. We need to get some understanding nationally what's happening. I do support cytoreductive surgery, not only in ovarian cancer, we do it now in colorectal cancer as well. But I think these surgeries needs to be done in centers where there is a support from NHBB colleagues, and shouldn't be done outside these areas where NHBB colleagues are not available. And I hope that doesn't have any further objection from you. Yeah. So thank you very much, and I think that's the end of my talk.
Great, thank you very much. I'd like to call upon Norma Gibbons, who's going to talk to us about the urological side of things. I also see that you support the placenta accreta service, which must keep you busy.
Now and again. Now I'll just have to see what for pressing. Oh yes. Good afternoon. It's rather daunting to be the only urologist in front of all you gynae-oncology surgeons, but I'll do my best. I've been a plumber since 2008 when I was appointed to Imperial, and I've been inside a lot of different operating theatres, which I enjoy because probably I'm quite inquisitive, and it is great to operate with other specialties. I think, and I do continue to learn from other subspecialists. So basically, the urologist and the gynecologist really need to be a well-oiled married couple, is what I think, because of these ridiculous tubes that go from the kidneys to the bladder. They get in the way of absolutely everything. So we're always going to be bound by that. So when should we operate together? Well, definitely for total TPEs. For any patients with hydronephrosis or hydroureter or invasion of the bladder, we should at least know about it or be involved. For non-functioning kidneys, at least to know about it to see whether you take the kidney out at the same time or just tie the ureter off. Any patients with anatomical anomalies, such as a pelvic kidney, horseshoe kidneys where the ureters run anteriorly, duplex ureters. It's bad enough having 2 ureters and then turn up and then you have 4. It's not great. And patients who've had previous urological surgeries, such as high ureteric reimplantations or augmentation of the bladder with bowel. My bugbear is radiotherapy. There's always going to be urological related complications with that, and I thought maybe as part of our wider discussion we could discuss that a bit further. A mentor has always said this to me, the 6 Ps, and that goes for every surgeon who goes into an operating theatre. Be prepared, okay, because you just never know what's going to be ahead of you. MDT working. It's really important that we're involved from the very beginning. More and more as well, I think, knowledge of the radiation fields, where the radiation has been applied in the abdomen or the pelvis, and also the doses. And the other thing is to really inform the patient, because I think the more informed the patient is, it's almost like giving the death consent. When you manage their expectations, you can actually manage any complications post-operatively. It's when you don't consent them for absolutely everything and then there's a surprise. I think that's when you're behind the ball. Pre-operative, I personally like DMSAs if one of the kidneys looks dodgy, CT urogram, optimization of renal function, whether a nephrostomy goes in, and occasionally you may need to get an nephrologist involved. I'm not saying not to call for surprise intraoperative calls, but try and avoid them by being prepared. Because oftentimes there are some units who have the luxury of flexibility and being able to go in and out of each other's theatres. I don't have that. I actually work cross-site. Really important to operate together. Respect is a big thing, isn't it? You need to respect each other as subspecialists and also to make joint decisions interoperatively. That gives for better outcomes for patients. Co-management post-operatively, when to take the drains out, when to take the catheters out, and so on. And on call, that is another thing, again, I think we should discuss, because as urologists, we are getting more and more subspecialised. So in actual fact, I have more in common with gynae-onc surgeons and with colorectal surgeons than I might do with some of my colleagues in the department. This is briefly a patient who basically had a cervical cancer. She had a TPE. I took her ureters up very high to the renal pelvis. We had to do a wet colostomy because her bowel looked like that. And that's her pelvis, charred. And although she's alive 3 years later, we're still dealing, shall we say, with the intermittent complications of that. The location, all I will say is anywhere there's surgical expertise on tap, any places where the theatres are equipped to deal with major cases. Interventional radiology are really important. They've bailed me out many times because they're stabilisers and proper anaesthetic and HDU support. Now, I have answered this question, so I'm going to be shot. But it's not about ownership. It's really about the best outcomes. The higher the risk, or the higher the complexity, the greater the risk. So it goes for all of us. If you can't deal with the complication, it's like the liver. I'm absolutely petrified of it. I'm petrified of the pancreas. I don't want to go near those areas. If you cannot deal with a complication, don't do it. That's all I would say. These are the areas that I think we should be involved with, but again, it depends on the expertise of the actual gynae-oncologist. And opportunities for research, again, we can discuss this, but I think a passion of mine would be education and training, and basically to promote cross-fertilisation of surgical techniques are important. Thank you.
No, perfect. Good. Thank you very much for that. Next we have Jim Khan, Professor Jim Khan. Is he here? I don't think he's arrived yet, has he? In which case, can I ask Sandeep to deliver his talk? So just for the control room, we're moving on to the vascular surgery section by Mr. Sekar. You'll just have to get the presentation. There we are, we've got it. So Sandeep's a colleague of mine at the Royal London, and we all need a vascular surgeon sometimes. So please do educate us.
Thank you. Thank you, Arjun and Ranjit. What an amazing honour it is for me to speak to such a learned and specialised group of individuals. I know because I work closely with you, and I have done since training. When we trained together, Ranjit and I trained together, and I learnt from Arjun as well as a registrar when you worked with my own consultant, and I think vascular surgery has learnt so much from gynae-oncological training as well, and we've certainly all been involved together in that. I'm not really sure I need to give a talk because everything we just heard about the other plumber is exactly what I think. I'm also a plumber. I'm only 18-minute cycle away from here. That's my building. I've hidden the helicopter pad at the top of the building, and that's because actually vascular surgeons don't like blood. We like not to see blood, When we see blood, our outcomes are worse. Just because we may have to do some trauma doesn't mean that we enjoy that blood. We certainly don't enjoy it at 3 in the morning. And the reason I say it is because all of the work that we try and do with you is not seeing blood. And what can we do to not see blood? The point about being a technician. Now, actually, I'm a technician as well. We'll talk about why that is. Coming to the questions that were asked, which should stimulate our discussions, what should be managed jointly? Well, for me, it's quite simple, isn't it? We've got very large vessels in the back of the abdomen, in the retroperitoneum, and quite often whether something can be completely removed or whether it can't be completely removed comes down to whether you can take it away from those large vessels. The extent of involvement of the vascular surgeon, to be honest, is to do with the experience and familiarity of both people. So I'll explain. Ranjit and I started our consultant careers together, and we would do our cases together. And then slowly we would push me into clinic more and more and more, and I would come only for the part which I would want to come for and to help with. And now, actually, quite often we have cases where I get through a whole clinic without coming at all, because as time goes on, we work together and do things together. However, I would say, what do you want me for? Really, you want me if you're going to go into one of those vessels, ideally before you go into one of those vessels. That's the key, because once you go into the vessel, I can probably fix the situation slightly better. Not necessarily, but probably I can slightly better. And then the other thing is the anatomical location. I would say that it's quite difficult to do work at the renals, at the level of the left renal vein or higher, without your vascular surgeon there. Okay? So at the beginning of your career, I would suggest your vascular surgeon would be with you a lot more, but as time goes on, you will need that surgeon to be there less. However, how does it actually work in reality for a patient? Even if I'm not going to be in an operation where there's vascular involvement, early involvement of the vascular surgeon is essential again. These are the same themes. An early discussion of risks and complications of the vascular exposure, because those patients are going to need to make their decisions on those bases as well. I routinely take imaging from your patients to our MDT to assess what my colleagues feel about whether tumours are going to come off, whether there's a plane, what am I not thinking about, and what problems should I be preempting. As I say, vascular surgery is a preemptive specialty. Perioperatively, that information will be used for consent. I have to say, I don't come to consent. I think I would cause more worry and consternation in consent, especially if consent is on the day. But we'll have already discussed what the consent issues are, because the kind of things that I may have to do will have direct implications on quality of life, and possibly even on whether the patient survives at all. So the success in terms of mortality. So those elements need to be discussed very carefully. Intraoperatively, I've written that you define the availability of your preferred vascular surgeon at any point in the procedure. So I wouldn't do operations where you may need a vascular surgeon if you haven't got your vascular surgeon ready. In my hospital, I wouldn't necessarily say make that the on-call vascular surgeon, because remember that helicopter. So have your vascular surgeon, have your relationship with your vascular surgeon through your career is what I would suggest. And have a plan, or have the vascular surgeon have a plan B if they're going to be stuck elsewhere. Team brief is very, very important for vascular surgery. So I would often come to the team brief because I'm using theatres I'm not completely familiar with, but potentially a team I'm not completely familiar with. There are certain adjuncts which I rely on, which you wouldn't be using. So cell salvage, for example, something I routinely would use, you wouldn't be using it. So that's important. And then most of all, the vascular equipment. People are not necessarily familiar with how to prep vascular equipment, what equipment to have. So team brief is very important for us. Post-operatively, we always have to be available for complications. Complications of vascular surgery are usually immediate and spectacular, of course. And of course, complications drag through to outpatient services. Vascular surgeons see more and more patients for a longer basis with more and more follow-up for these reasons. Where do we do it? Well, it's obviously in theatre, but it needs to be with a team who are able to support major open vascular surgery. If things are going that way, we redeploy staff from elsewhere. We actually have 2 floors of main theatres. And that there are logistical things, but our services are aware that we may need to do things like that. The ability to support significant bleeding, even without cell salvage. Arterial equipment, as we discussed. And the ability to flex in terms of where the patient goes afterwards. Are they going to the post-operative care unit, or are they going to true HDU? Are they going to ITU? We need to be able to flip between these things. And of course, a service that has vascular 24-hour on-call. Most people dodge the question. Actually, I'd say it the other way around. I would say in a gynae-onc case, the gynae-oncologist is the lead and in charge. I'm just being asked, can I help to make this patient's life better afterwards? And sometimes I can't, and sometimes you need to look and see and realize that you can't. And I'm probably in a good position to be able to do those elements with you if the blood vessels are involved. As I said, I think if you're going above the renals, then probably a vascular surgeon needs to be involved in that part of the operation. Research opportunities, I mean, we're very focused in vascular surgery on procedures. But it does strike me that the patients can have higher resectability, potentially, if we didn't have a lot of the vascular worries and fears that we have. For example, if I put grafts in to the retroperitoneum where you've stripped the peritoneum, I'm worrying about fistulas with the bowel, and I try really hard not to do that. But do I know that that's going to happen? What about using grafts which are biosynthetic hybrids? Do I know that they're safe and they're not going to cause fistula, but they allow me the tools to allow full resection? These are opportunities for research, and if they happen, then they'll have to probably be national or international research because of the small numbers involved. Thank you very much.
Thank you, Sandeep. Could I ask Kieran Power to come and give a talk on the plastic surgery perspective? We work very closely, obviously, with our plastics colleagues, and the sort of reply that you love to hear is, just remove the tumour and I'll fill it. So we look forward to hearing your thoughts. Thank you. Great. Well, thanks very much for that. And last but not least, my good friend and colleague, Sarab Fadnis, who many of you have heard speak at this meeting, is going to round it off for the home team, as it were.
Thank you, Arjun and Ranjit, asking me to give a perspective on gynae-oncology. Talking about teams, the England team is fallout at Lord's. Right, so the first thing is, I think in advanced gynecological cancer, we have to accept that we are dealing with a disease that is anatomically multivisceral. So we need help, and we are going to work together. And such a great MDT we have put together today. So we often work with colorectal, urology, plastics, HPB, vascular. I've worked with breast surgeons in primary dual-site disease or even in risk reduction. We've done some risk-reducing surgeries together. I meet my colorectal and HPB colleagues more in the pub rather than in the theater nowadays. And that's to do with, we've shown our outcomes that, the skills are transferable, and more often than not, we can deal with colorectal surgeries as well as complications on our own. That doesn't mean we don't ask for help. We do ask for help, if there's a patient who is at risk of intestinal failure, or if there's a complex HPB case. I wouldn't be doing pancreatic surgery on my own, or gallbladder, even for that reason. I would also, I always call the HPB surgeon. Where, when, and who should be doing it? Where it's quite clear, these surgeries need to be done in places where we have the expertise of multidisciplinary teams. And probably, we know that there is wide variation of practice across the country. It's quite clear from the National Ovarian Cancer Audit. But we need to accept that we've got to do these surgeries to get the outcomes that we need for our patients. When do we get involved, or when do the multidisciplinary team gets involved with our patients? I think, just to give you an example, so me and Arjun did an exenteration last week, and for that patient, it was quite clear. It was a total translevator exenteration with total valvectomy, needing an ileal conduit and plastics. So that was identified in MDT, and when we first saw the patient, the urologists were already informed. So the urology consultant saw the patient immediately after our consultation, counseled regarding ileal conduit, and we actually saw the patient together with the plastic surgeons to plan the surgery. So it was well in advance, and we were well prepared. And when the actual surgery, took place, it was 6-7 hours. So we were well planned and good outcome. The patient went home on day 8. Talk about research. I think there is need for regional collaboration as well as national collaboration. I think we need to look at capture the nationwide variation, why this is happening. How do we help? We need baseline data with that regards, and also I think we need to focus on quality of life. These surgeries are far complex, and I think quality of life is an important topic that we need to address. What should the gynae oncologist not do? Well, the first thing is the gynae oncologist should have insight about what they can do. And I wouldn't be doing pancreatic surgery or complex plastic flaps. So the first thing is insight, because if you don't have insight, and certainly, I wouldn't be doing surgeries where I can't deal with the complication. So, we don't do ileal conduits because we don't do that many. And what's the threshold at which you say that you're comfortable doing this surgery? How many surgeries do you need to do in a year? All those questions are important. And let me show you how a good team works. Talking to each other, but they're doing a perfect job. And everybody knows what they're doing. Great, thank you.
I like that.
Well, thank you to all the speakers for keeping to time and informing us of your areas. But themes that have really come through, common themes, have been meticulous planning, absolute respect and regard for your surgical colleagues. It's absolutely key. You've got to build these relationships. These are long-standing relationships that take years to develop. And forewarning, sort of being called unexpectedly to theatre to sort out a problem can be, it's not ideal mainly for the patient, but also stressful for the surgeon involved. The other theme that I thought was really important and came through loud and clear was don't do an operation if you can't deal with the complications. Okay, I'm very clear on that. Many years ago, we do conduits, and if you do 2 or 3 a year, you shouldn't be doing it because the complications of a conduit can be, serious. But just to get the ball rolling, that sort of leads me on to the subject of what's acceptable and what is accreditation and, is it all right for GYN oncologists to take out the rectum and reanastomose? I mean, we do it, but at what point will our colorectal colleagues turn around and say you shouldn't be doing that? I think that's the sort of elephant in the room, if you will. Can I ask Norma to comment?
On colorectal?
No, about operations that you don't do. Comment on a conduit then. The complications of a conduit are not insignificant.
No, they're not. I think the issue is I know that most people can actually technically do it. It's the nuances of what happens post-operatively. Everything is fine until there's a problem. And then what do you do? How do you deal with a leak? Do you take the patient back to theatre? Do you put nephrostomies in and sit tight with the drain? And then there's the long-term complications with renal dysfunction, with upper tract dilatation, and consequent renal failure over a period of years. I think an ileal conduit is quite a dangerous one to do if you're not a urologist. And this is out of respect. Even in my own department, there would be probably of 21 people, there'd probably be only 5 who would do ileal conduits, because I don't know about other subspecialties, we've become very subspecialised. There are some colleagues in my department who just do prostate, absolutely nothing else. There are others who just do andrology. And that's what I'm talking about, the cross-fertilisation of the pelvic surgeon. But I really, and this comes from me as well, I can put a stapler across the tail of a pancreas. I can do that. But what do I do if it leaks? Freak and run a million miles away. You got to let the specialist put the stapler across the pancreas, because they then own it afterwards. And I'm not talking about, you own this bit and you own that bit, because we do have to work as a collaborative team. But I do think ileal conduits are a dangerous game, to be honest.
Sure. No, you're absolutely right. Kieran, do you want to comment about flaps and sort of cutaneous flaps, vascular compromise, etc.? I certainly personally wouldn't undertake something as complex as that for the same reason.
Yeah. Say in the exenteration setting, there are surgeons who will do some flaps. They might do eye gap flaps. And I think, it looks quite easy actually, but how you inset it is the critical thing, and maybe they don't quite, maybe slightly better insight into that. But and it's the downstream complications that delayed wound healing or herniation or prolapse, which is a common thing with, say, eye gaps, and then maybe you think maybe you're someone who can do a rectus flap, but in specific patients, especially if there's two hernias, well, a rectus flap should really be avoided because you're going to trash their abdominal wall. So the difference is with the plastic surgery, I think, is that we have lots of potential flaps. We can do gracilis, we can do lotus petals, we can do groin flaps. So we're looking at really not from I can do a flap, I look at it, well, what size is the defect and what is the best option out of the 5 flaps I can offer versus 1 flap. And then, of course, it's also managing things like the complex wound management, because these wounds are really complex. And having input from plastic specialist nursing and that team is really important also.
Absolutely. May I throw it out to the audience for questions? Ranjit.
Thanks. I guess one of the issues to delve into also is to look at it from a multidisciplinary training perspective, and how to sort of bell that cat, because that's not an easy thing to do. I mean, if you have a trainee coming in who's going to spend 2 to 3 years in the team, and we have to go through all the different subspecialties which are important as gynae-oncology surgeons, and what is the comfort level, what is the level of competency that person should achieve apart from the gynae-oncology skills? Then when he goes into another subspecialty, you're competing with the trainees in that subspecialty. So there isn't really a systemic way. I think maybe the local solutions and local training programs, but there isn't a systemic way that this has been addressed. And I sort of feel we've come a long way in our evolution. And that's something we do need to consider as a broader community of colleagues, who, as everybody rightly pointed out, we have for the patient good. And I just wonder what people thought and the opportunities really to modify training. Similarly, there may be things that other surgical specialties may feel their trainees may benefit from coming in, working in gynae-oncology or other surgical specialties for that matter. And they're just at the college level or at the system level, it's not properly addressed. And may I ask, some of you at least, to comment on a difficult subject?
I'll just make a quick comment, and I'm then going to hand over to Sarah, who'd like to say something. I mean, just to praise my surgical colleagues, I mean, one of the better things the RCOG has done is organize structured subspec training. So to be a gynae-oncologist in this country, you've got to do a 3-year fellowship program, have a research exemption, et cetera, et cetera. Again, the elephant in the room is quality of training. But I'll hand over to you, Sarah.
Ranjit, thank you. That's a very important point you make. I think I've got 2 points. The first one is when we have fellows, and I can see there are many fellows here, I always tell them that when you're doing your fellowship, make friends. When you're going for your modules, that's the time to make friends. Because when I've made friends and we've become consultants together, we're working very nicely. That's the first thing. The second thing is I think regionally or even nationally, we need to work together. It's already happening. We've got the Basingstoke Fellowship set up via the BGCS. I think we need more kind of collaborative working in terms of training that way. We can probably think about doing it regionally. That might be suitable because we work closely with Marsden in terms of our training. I think that's one way to deal with this.
Would you like? Yes, please.
Ranjit, that's a very good question. I can't agree more. I think for a proper training, you will need interdisciplinary transfer between subspecialties. And if we remember 25 years ago when the breast surgeons started to do the oncoplastic surgery, they used to go to plastic surgeons to learn from them how they do it. And some of the plastic surgeons actually came to the breast surgeon to know how to do oncological resection as well. And I think this is to start with, to build up a future for a gynae-oncology that is essential. Does it mean that who's trained in that pathway, integrated pathway, is going to be confident of doing, for example, a pancreatic resection But if he's doing it only once, no, I don't think that will make him confident or competent doing pancreatic resection. But I totally think that he will do lots of part of the surgery without the HPB surgeon present.
Yeah.
And then the HPB surgeon need to be, so that will be time consuming, saving for manpower, as well as time saving for other people. So, thank you.
Thank you. I'm just a little bit conscious of time, but we'll take a further question. Thanks.
Thank you. I'm going to apologise in advance. I'm going to be deliberately inflammatory in what I'm saying, and it's no disrespect to everyone because, you know, I totally get it. But I think there are different...
That's what we like.
Jolly good. There are different questions here. There's a total pelvic exenteration. There's the radical cytoreductive surgery in ovarian cancer. There's, you know, the plastic surgery involvement in the big vulval resections, etc. And they're different beasts with different patient numbers coming through. And my point is about ovarian cancer cytoreductive surgery. I'm in Wales. I'm in the smallest centre in Wales. And I am proud that on the figures on that audit, I am very much in the top section of the results. And yet I have access to very few of you guys.
Yeah.
And the reality is that we're transportable. We might not like it. I might not want to leave my little corner of North Wales where I've got 5 acres, stables, etc. But I am transportable. But theatre capacity is not. And the numbers that would be needed to get through and the theatre capacity that would be needed for ovarian cancer cytoreductive surgery if we were to try to centralise those sort of things, it's just not physically possible. The hospitals and the theatre capacity is not transferable. Does anyone have any ideas? Does anyone have any thoughts about transporting the surgeons, the HPB input, etc.? So we massively struggle in North Wales to get any of the specialist input. And we'd quite happily set up, for example, contracts with people to come, you know, 1 day a month, link you in via Teams to MDTs, etc. But anyone, any thoughts on that? Because we're drawing blanks at the moment.
So I come from a background where we're trying to reduce the number of centres performing retroperitoneal sarcoma surgery from 15 to 5 in the UK. So I suppose I'm surprised to hear that you're on your own doing this kind of surgery. I think it's probably quite a vulnerable place to be, and I think you'd probably admit it's not ideal. So should people travel further? That would be my solution, actually.
But I just said there's no capacity for people for like ovarian cancer. That's the problem. I'd send them elsewhere. There's no capacity for them to go.
Yeah.
I liaised with the Marsden quite a lot recently, and I've sent things there that I'm just like, we can't take this on. But there's no capacity for them to go elsewhere. I've had to give my neoadjuvant chemo patients 6 cycles of chemo, and even then they've struggled to fit them in because they're busy. I can't create more theatres.
No, the way we're addressing retroperitoneal sarcoma, I don't have an answer to this, obviously. It is ultimately we are saying that the resource has to follow the patient. So what you don't want to do is go from one service that's struggling and then overwhelm another service that's performing well, and so that everyone loses, the local patients and the people that have travelled. Clearly that's the risk. But I don't know that's for us here. I think the model is that we have multidisciplinary working.
Sure. I mean, what's coming through loud and clear is that these complex operations needs infrastructure.
Yeah.
Doing the operation is the easy bit. It's the pre-op workup. It's the ITU care. It's all of that. Mr. Chairman of the organising committee, we're overrunning. Am I allowed to keep going for another 5 minutes because we've got a couple more questions, or is someone else expected in here? Go on, ask your question. Ask your question while we're waiting for an answer. Come and ask.
It is coffee break after this one.
Okay, so we can continue for a little while. Yeah.
I was just going to make a comment about centralisation of services, having been a trainee in a very busy cancer centre in London and now living in Cornwall. The issue that we always forget, especially I worry about policymakers in cities, is actually talking to the patients. We have patients in Cornwall who, in urology, don't want to cross the River Tamar into Devon to have an operation where they save half their kidney, and they would prefer to stay in Cornwall and have their whole kidney removed. And so what you will find in this situation is elderly ladies that are fit enough for debulking surgery, they just won't have it. And therefore, you are reducing the availability if you say it's centralised to the 5 major cities in the UK. So just something to consider.
If I can just come back on that. So bone sarcomas are centralised to Birmingham from the whole of the West Country. So patients come from Truro, Cornwall, to Birmingham to have long bone and pelvic bone surgery because it's not offered anywhere else. So patients will travel, actually. It's about making it easier for them. People don't like to travel. So it's about the parking, it's about the expense, and it's about the organisation at the other end, that we have one clinic appointment that leads to their preoperative assessment. They see the specialist nurse, they see the plastic surgeon, all on one day. And then on another day, they come and have their surgery. We've done a survey with Sarcoma UK recently where people do complain about travelling, but they don't complain about the service when they get to the centre. It's about the hassle of getting there, and that's where the NHS and probably third sector, we let patients down. You know, if you have to travel 5 hours a round trip and then pay 30 quid to park, clearly that's not going to attract many people.
Well, in the US, they'll travel across the continent to get to MSKCC, won't they? Yeah.
The problem is you see the ones that want to travel. You don't see the patients that are never referred to you in the first place because they don't want to travel. That's what you have to consider.
True. And Jane, I understand your point, but I don't think we need to over-centralize gynae cancer care anymore. We've already centralized gynae cancer care. I think it's to do with looking at what is available in your patch and how do we work together. Because I think that's what we need to concentrate on rather than logistics of over-centralization.
We work with our neighbouring networks in a similar model for advanced ovarian cancer. Go ahead.
Thank you much. That's very interesting. I think relationships are key here, and we had loads of HPV input, 8 years ago, and now we have none. Once a year we ring them up and say we've got disaster, and they're always awful cases now, basically. But the run-of-the-mill stuff goes through and it's fine. Just going on to the numbers, we need 100 surgeons or 100 operations doing 50 a year, fundamentally. And if you have a multidisciplinary team which is set up with 4 to 5 surgeons coming with different specialities, this becomes a very expensive operation, which is not what it should be about, but it's an important consideration. The question which I was going to put forward, though, was one of the issues we have is that lots of surgical specialities do not deal with disseminated peritoneal disease. Okay, so if, say colorectal cancers, unless you do colorectal adenocarcinomas, your tumour is defined to your organ, same with elements of urology and the like, okay? And one of the issues which we have based on the limitations of imaging, for example, identifying, nodes which may be behind the IVC, is what do we do when we find something which is a bit different and someone else needs to come in? Okay, because that brings in a very significant challenge, actually. It puts that person who is coming in a very difficult situation. It gives us people, our teams, people which don't know how we operate, don't know how the disease is managed. And I think, the risk is that someone says, this cannot be done. We're going to stop now. Now, we never want to come to that situation, but we know that our CTs are not perfect. How do we rectify that without having a 10 PA operation per case?
I'm going to ask Sandeep to answer that question because you're probably more used to being called into situations like that.
Yeah, I think your point is a very good point. In fact, I think it's a bit worse. So vascular surgery, the old system of vascular training was general surgery. I'm a general surgeon who now is de-skilled in pretty much all of general surgery. But more and more our new consultants are endovascular surgeons. And we've set up teams where if they end up having to do this kind of work, they'll buddy up with one of us. So if you're relying on the on-call, something may well be unresectable, although a few of us are confident to go round behind the aorta or in the gap between the aorta and the IVC. It's a big issue. The way we deal with it is a buddy system in our hospital, but I completely accept the point, which has been made several times, which is that you can't really do that. I work in a specialty where actually the operative exposure is a lot to do with being in the right place at the right time, or you could argue the wrong place at the wrong time. So we're okay with that, but in most specialties, it's not quite as responsive. I agree with your point.
Thanks very much. I'm being told off majorly for overrunning. So this is great. It's been a really good discussion. The take-home messages are very simple. Get on with your colleagues. Thanks very much, everybody.